Hi everyone. It's 10:15 and let's get started. Don't know about you. I thought this morning's session was highly educational. We learned a lot about AI, about the rigor room.
Yep.
But this session is actually the most important because this is where the rubber meets the road. On Monday morning, when in the clinic and your patient asks you about focal therapy, here are the answers. So I'm very happy to co-moderate this with Dr. Siva.
Hi.
And Dr. Amir.
Yep. Still waiting for Dr. Amir to get his phone charger.
But I understand that Dr. Ruben couldn't make the flight because of the cyber attack. So he sent a video, and I thought we should just let him run his video, and
Yep.
We will answer the questions later. You want to introduce him?
Yeah, sure. So introducing our first speaker via video, Dr. Ruben Olivares. He's a surgeon and associate professor of urology at the Cleveland Clinic Lerner College of Medicine, Case Western Reserve University. Specializes in minimally invasive therapy for treatment of localized prostate cancer, significantly contributing the area of that area of medicine. He's earned his medical degree from Universidad de Chile in Santiago. After graduation, joined the Department of Urology at Clinical Santa Maria, Chile, where he dedicated himself to robotic surgery and the development of TP MRI fusion biopsies and partial gland ablation for prostate cancer. He played a key role in organizing the fellowship program at Clinica Santa Maria and actively mentored and trained numerous young urological surgeons. Upon completing his fellowship training, Dr. Olivares joined the Glickman Urological Institute at Cleveland Clinic in Cleveland. During his tenure, he focused on advancing research in localized prostate cancer and minimally invasive surgery. Dr. Olivares has established a notable international career as a skilled surgical proctor and cancer researcher. So we shall play his video.
Dr. Siva, you should introduce yourself as well, no?
Yeah.
Everyone,
So hello,
I'd love to be
I'm
there
Dr.
with you
Siva
all in
from
person
Hospital
today,
Raja
but
Permaisuri Bainon Ipoh, Malaysia.
Hello, everyone. I would love to be there with you all in person today, but unfortunately, I had some flight issues on my way there. First, I would like to extend my thanks to the organizing committee for putting together such a wonderful meeting. Today, I will be discussing the critical role of the multidisciplinary focal therapy tumor board in management of patients with prostate cancer. This multidisciplinary team is crucial in personalizing treatment plans and, of course, improving patient outcomes. I'm Dr. Ruben Olivares. I'm urologist, focal therapy program lead at Cleveland Clinic. I don't have any conflict of interest for this presentation. This slide illustrates the adoption of new technology in the US. The telephone was invented, so to speak, just before 1900. And it took nearly 100 years, and still not today, not everybody had a phone in the house. But there was an adoption over time. As you can see, a lot of things, for example, television. Most of the adoption of the technology, especially in the first half of the last century, took 20, 30, 40 years to adopt the technology. One notable exception was the airplane here in the middle, in the red line. Once it became commercially available, and it was adopted very quickly. As computing capacity has increased, as community capacity has increased, that you can get new technology that they be adopted almost immediately within years. In urology, for example, it took about 15 years for the robot to go from virtually no usage right in the 2000 when it was introduced to more than 95% usage in the recent years. So we will observe this trend faster and faster. So many patients are looking for what is new in prostate cancer management. As clinicians, we often see like a fight between marketing versus science. where a lot of patients are keen to get new treatment, and focal therapy for prostate cancer is not a deception. I hope that we can get to the point where we can adopt this new alternative that deserve to be adopted in a faster period of time, and it doesn't require new generation. The poet, Miss Siborska, who won the Nobel Prize, said, "A new star has been discovered," which doesn't mean that the things have gotten brighter or that something we have been missing has appeared. New technologies and therapy, along with the vast information from internet, complicate adoption process. Patients often demand the best or newest treatment, but struggle to distinguish between evidence-based medicine and marketing strategies. Our role as early adopter and leader in focal therapy programs is to guide patients with accurate information and recommendation to help them to make informed decisions. So focal therapy is a whole new way of thinking about prostate cancer management. How we can guide the introduction of this new alternative to our institution and patient? The beginning should be organizing a multidisciplinary panel proposing a list of prerequisites that must be strictly observed when offering, delivering, following, and also reporting patients for focal treatment. Dr. Brigante, in this editorial in 2022, said an uncontrolled behavior might represent a risk for both patient and the potential future role of focal treatment because of the inaccurate patient selection and follow-up and the unreliable and misleading outcome results consequently provided. This is a meta-analysis from 2021 that showed that cancer multidisciplinary tumor board meetings has a significant improvement in patient 5-year survival. So we will changing the management of patient, and that change directly benefit patients. Baldacni report the 6-year experience after the launching of the multidisciplinary tumor prostate cancer clinic. Interestingly, they report that most of the patients with prostate cancer were staging in the low-risk group disease, but the number increased significantly after the tumor board discussion, from 40% in 2006 to 61% in 2009. Moreover, they report a high percentage, and about 80% of patients managed with active surveillance protocol after this option of discussion. This data, it's very interesting, and it just underlines that active surveillance, an approach today offered to many patients with low-grade disease, is more often an option in the on the multidisciplinary tumor board discussion, where the candidacy and the protocols are more standardized. With a tumor board discussion, we can help our patients that are often receiving contradictory information from the specialists they contact. For example, in this graph, with the same cohort, the patient will reoffer radical prostatectomy if the clinician in front of them are urologists, or radiation if they are seeing a radiation oncologist. We really need good communication to do well with focal treatments. The focal therapy tumor board avoid that sort of cowboy decision-making instead of evidence-based medicine, right? We want to make our decision based on evidence, not whoever is the most forceful speaker. And it allows a forum to sort of follow up of the results, to maintain a registry, a follow-up, for example, of the failure, and having the desired discussion that help us to build in a collaborative way and create the ideal patient identification. We will talk about who is the ideal candidate. So at Cleveland Clinic, we started the focal therapy tumor board about 2.5 years ago. We already have our multidisciplinary tumor board, but we felt at that time that this new treatment was unique and we need a new scenario that maybe at some point, or once the penetration of the knowledge is good enough throughout all the organization, we will merge back to our normal tumor board. But we want to have this separate the opportunity. In the absence of randomized controlled trials, we should do our best to follow the following principle to standardize, offer, and deliver focal treatment. Conduct both target and systematic biopsy, guided by high quality, with good report, multiparametric MRI. We have to ensure that the prostatic biopsy are reviewed by specialized uropathologists. We should ensure that the prostate MRI are also reviewed by specialized radiologists. And this fact is very important because we are not doing just a screening. We don't wanna report the dominant lesion. We have to see all the lesion throughout the gland to try to reduce the risk of reoccurrence in the area that it's gonna leave untreated. We must offer focal therapy only to patients with big volume, grade group 1, who refuse the active surveillance protocol, or those with unilateral clinical significant grade group 2. As we move on with our discussion in the focal therapy tumor board, we start applying the extended criteria with some unilateral grade group 3 prostate cancer patients. We must implement follow-up protocols similar to those used in active surveillance patients, with the mandatory confirmatory biopsy 6 to 12 months after the focal therapy to report outcomes. We don't need to start from the square one on this. We have different experience, and one of them is the experience from Dr. Tai, who created and organized focal therapy tumor board, in this case, a virtual platform endorsed by Focal Therapy Society, when we can all meet and discuss our patients. At Cleveland Clinic, we have our focal therapy tumor board, we have our uroradiologists and uropathologists and urologists, and we invite radiation oncologists. We also invite med-onc, but they are able to come, though of course this is localized cancer treatment, so they probably don't need to be there. If the path biopsy was outside, we have our own uropathology review, and most of them were reviewing, even though many of them was done initially at the Cleveland Clinic, but they must be reported through the eyes of focal therapy program. So it's a different mindset. In this paper published in Urological Practice 2023, we report our initial experience. We went back the first 6 months of our focal therapy tumor board, reporting the first 75 patients. Those patients was sent by all providers to urology of our network that they thought that it's going to be a good candidate for focal treatment. Many of them came from the patient, and the patient was very keen to accept focal therapy. On the right side, you can see a table with the baseline characteristic of a bigger cohort of 215 patients. As you can see, most of them has Gleason score intermediate risk, but some low risk and some high risk. And also, you can see the distribution of the MRI findings as well. The bottom line is the results that after we review 215 cases sent to our focal therapy tumor board, only we conclude that 37% of the patients were good candidates to receive focal treatment. For sure, we were very restrictive on our criteria, and we will talk about what is the reason that we thought that maybe radical or whole gland treatment or was a better idea, or the patient needs more workup. Interesting, the number of rejection was even higher when the MRI was performed outside the Cleveland Clinic, just highlighting that is different to evaluate an MRI using the eyes and the criteria for focal treatment as compared with regular screening. So most of the time, the patient that was deemed not a good candidate for HIFU, that it was our initial source of energy to offer focal treatment, was because the review of the MRI. One of the largest single reason was that the lesion was crossing anteriorly above the urethra. But in 20% of the cases, for example, we found new lesion outside the area that we were thinking to treat. So it's just highlight the importance of a good and dedicated radiologist to help us about candidacy for focal treatment. Other time, we felt that we have not enough space to get treatment without risking the external sphincter. This is a confusion matrix. This is when you have the first read of the MRI, and then you have the overread with the eyes of focal treatment. And you know, in ideal world, this green line would encompass all the patient, but was actually only 60% of the patients. 40% of the patients who had an overread with the eyes of focal treatment had a different read, and the majority of those were more concerning, identifying new lesion or more concerning lesion, and therefore many of these patients will necessitate more workup to be considered for focal treatment. Most of the time we recommend new biopsy, for example, if the lesion is anteriorly located, using a transperineal approach. What about pathology review? This was very interesting for us. Our pathology often ruled them out because the presence of grade group 1. 40% of the patients, especially those patients who came to the discussion with low volume, one spot grade group 2 prostate cancer, were downgraded to grade group 1. So active surveillance was the recommendation. In those 31% that didn't meet our kind of recommended criteria ahead of time to receive focal treatment, in the focal therapy tumor board, we have the opportunity to debate, to discuss. And also, we gave some kind of board recommendation that helps to alleviate the urologists from having to turn the patient down, because those patients are convinced that the only treatment that is good for them is focal treatment, even though the presence of high volume grade group 3 prostate cancer or multifocality. So we carefully wrote down a board recommendation telling that you're not good a candidate and you should evaluate whole gland options. In conclusion, I think that the multidisciplinary team in the focal therapy tumor board discussion are a good way and a collaborative way to launch a focal therapy program. Then will be very helpful to keep your program going, and also for standardization in follow-up, outcomes, and report. We think that we all will see benefit. For example, if you are a urologist who are not in the front line in the focal therapy field, to receive education about candidacy, follow-up, and potential complication. At Cleveland Clinic, in our experience, The focal therapy tumor board changed the management of our patient in about 70% of our patients. So it really changed management, and we think that it would change the outcomes. Also, as we talk, change the mindset for radiologists and pathologists who are seeing the same test, but with a different eyes, focusing in focal therapy criteria. So I'm gonna conclude here, and thank you very much for your attention.
We are running a little bit short of time, so we'll leave the questions towards the end. I'm Chris Ching, and have the greatest pleasure introducing my longtime friend and collaborator, Dr. Lawrence Cox from Sunnybrook, Toronto, Canada. He's well famous and need very little introduction. He's invented active surveillance, and I guess very involved in focal therapy. This morning we learned from him about having wriggle room, but he's going to talk to us about MRI invisible clinically significant cancer. Laurie, take it away.
Thank you, Chris. Hang on, I got some. Notwithstanding the fact that I submitted my talk about 5 times online, they've asked me to give it from my computer, and I just have to get it up. Hang on a second. Just a sec. I'm going to unplug.
Yeah, that's why you should never send your talks in advance.
So just a couple of quick comments while hopefully the talk comes up. I was here as the national guest about 8 or 9 years ago. More like 10. You spend a week, visit every hospital, really a wonderful experience. So I really got to know Singapore. It's wonderful to be back. My talk is called Visible versus Invisible Cancers, Genomics and Natural History, and what the implications are for clinical practice. So why don't you put up the talk that I submitted? So at least I have something to, can you do that? Yeah, I'm not sure what the problem is here, but too bad. Network error, cancel. Because I submitted the talk many times. You don't have it? Yeah, go ahead. So I'm just going to plunge into my talk. It's always the test, does someone really know what they're talking about if they can give their talk without
Laurie,
slides?
shall we just move on to the next talk while they sort this out?
It's PowerPoint presentation. Just find PowerPoint. If you want to do that,
Yeah.
this shouldn't take long, but I'm not sure what the problem is.
Yeah.
All right.
Okay.
Can we bring up the next talk?
All right.
Next is Art.
It's my honor to introduce Dr. Ardeshir, aka Ard Restinahat, one of the pioneers in the field, did his fellowship at the NIH and helped the program there to develop the MRI ultrasound fusion platforms. Now, I want to make it right because otherwise he yells at me. He is now a vice chair of urology at Lenox Hill Hospital and 2021 Arthur Smith Award winner for innovation from the Endourology Society. Dr. Restinahat, the floor is yours.
Oh, it's a pleasure to be here. I'd like to thank Jack and the organizers. I'm always excited to come to Asia and meet new friends and talk about what's going on. My talk is more of a question than any facts. And I think the challenge is we're trying to push the limits in focal therapy, but how much pattern 4 is accessible? You heard different things from different speakers this morning about what can be imaged or not. I can do Dr. Klotz's entire talk in one sentence. If you're using a GE scanner, tons of things are invisible. That's for a joke on the inside for the radiology colleagues out there, but is it not true? So everything you know about imaging is really dependent on what tool you are using to image. I think starting my talk is how much pattern 4 is possible and what should we do. I gotta remind everyone we're surgeon scientists. We're not cowboys. We operate on the principles of safety, efficacy, and do no harm. Above all, the patient comes first. It comes first, and the reason we're exploring this in prostate cancer today, we feel over-treatment and has led to increased number of harms to our patients with respect to quality of life, and we're trying to find a better way forward. To go over basically our risk stratification, we know we have different groups of prostate cancer. We know that unfavorable and favorable intermediate prostate cancer is separated by more than just the Gleason score. You could have a Gleason 3+4 with a bilateral palpable nodules or greater than 50% of the core. You're in essentially an unfavorable intermediate risk prostate cancer. And I think this is important to understand that these other factors. However, when we look at it, I don't believe if you have a bilateral palpable lesion, I don't think they're probably the best ideal candidates for focal therapy. So I want you to kind of peel that back and say, hey, that's probably not ideal. The 50% of a biopsy cord, Dr. Abreu talked about percent core. Percent core is, I think, just utterly useless in the context of an image-based modality because it should be the millimeters of cancer. Continuous or discontinuous is the information we should be gleaning from that pathology. Then talk about prostate cancer, right? We need to understand what are the outcomes and what are the events if we're designing a trial that determines how much pattern 4 is ideal. And if you look at favorable versus unfavorable, I'm going to scroll through the different levels, but prostate cancer specific mortality, you can see there's a difference, about 10% swing. This is how I discuss it with patients. The metastatic rate's about the same. And BCR, these are in patients with prostate cancer. We don't have specifically this data with respect to focal therapy, but this is what we're trying to build for us, because what is biochemical occurrence in focal therapy? That's really difficult for us. We use a tissue-based marker for this. And then for high-risk prostate cancer, I think it really puts things in the context. If you're doing a bad job, you're going to have higher recurrence rates. You're going to have higher incidence of progression of metastatic disease and possibly death. So we work through all this. These are the contexts. This is the baseline where you're thinking when you're comparing focal to standard radiation therapy. All that talking and all those things, I put this in 5 easy boxes for us. First of all, we get the information from our patient. How are we going to risk stratify you? And we've talked about the different tumor characteristics, the size. High-risk focal prostate cancer, I'll show you an image example. I think there's a place for us in this. The patient factors. I don't do focal therapy in patients with significant comorbidities that aren't going to have a 10-year life expectancy. But one space that I think is really underutilized, how many radiation oncologists here today? Okay, if you don't hate me. But in the US, urologists are not huge fans of radiation therapy. So that older patient with a focal grade group 3 disease, they're not sending them the radiation anymore. They're completely shifting to focal, which has caused a complete rift in our departments, that they're using more focal prior to taking that step to radiation therapy and ADT and the standard of care. So that's an area that should be evaluated. Functional outcomes is very important for our patients. That's why they come and seek this to us. And really our oncologic outcome is the baseline of what is possible pattern 4 versus not. Again, these are all questions and trying to stratify what's going to happen to your patient. There's an idea of progression-free survival. It's measured in a couple different ways. More than 2 focal treatments, and you go to a 3rd focal, that they've progressed. They have systemic therapy, whole gland therapy. That's considered that progression. It varies from paper to paper, so read it closely. A lot of our challenges in prostate cancer is, are we over-treating, and is focal therapy even helping the patients? This has been discussed ad nauseum, but just look at it. Metastatic disease incidence in radical prostatectomy versus watchful waiting, the difference was only about 16.7% in the overall cohort. In a study, I think, that's been talked about over and over, and they've done a great job looking at this. Yes, this was in a different era. Started so long ago that these patients maybe not applicable today. However, it's a better understanding of what happens in advanced prostate cancer. Taking a closer look, you look at the death from prostate cancer in different cohorts, it's almost twice as low, it's 50% less in a patient over 65 because there's other competing morbidities in deaths from prostate cancer. The metastatic events were somewhat similar in the 2 groups between treatment and observation. And again, it comes back to these patient risks. And are we under-treating tumors by doing focal therapy? What's your margin? What's too big of disease? I can tell you, I've run trials, and some urologists are just excited to get into focal. They're treating these really large lesions. They're probably taking on more than they can handle, and they do have a higher risk of failures. So when you talk about PIRADS 5s, high volume disease, how much can you treat? I think it's how good are you at doing focal therapy, but that also portends there's a possibility this is more aggressive variant. Dr. Klotz will get up and talk about, is it imageable, non-imageable? Is this a more aggressive phenotype or genotype in a phenotypic expression of a volume of disease that's imaged on MRI? These are our challenges today. Missing the secondary primary, like we talked about this, maybe imageable, which I have a study I'll show in a moment, but if it's an imaged disease, it's more likely more aggressive and we can see it, but we're also treating it. Therefore, we may be able to show a benefit in what we're doing in the focal therapy arena. And do we burn the oncologic bridge? I believe if you choose a patient that's going to be an aggressive variant, maybe a grade group 4 disease, focal lesion, are you taking away the opportunity for surgery or radiation? I think at this point we understand that surgery and radiation are still available and still options after focal therapy with minimal additional risk in the side effects. And again, I talk about the cancer control. Are we decreasing that metastatic risk? And these are the challenges. Again, my talk's more about the questions, not the answers, because we don't have data in this space. Like Tom and I were talking before I gave this talk, I'm like, there's really no data. There's no clear path for us to have an answer, but we have to go through this together. This is an example of a patient I had with a focal grade group 4 lesion. It's about 0.2 cc's. It's well demarcated. There's no signs of EPE. And do you think this could be a candidate? Like when you look at the patient, would you trade a grade group 5 disease? This is a 65-year-old focal lesion. I think this may be an opportunity for us. A lot of our risk stratification, again, is based on old data. And that's the challenge. All of our models, all of that stuff is based on old data. Fusion biopsies, we talked about, imaging, all this stuff is in this century, not the last century where most of our prostate information comes from. This is an example of a essentially unfavorable intermediate risk patient with somewhat high volume disease on the anterior portion of his prostate. He underwent focal therapy. He's been disease-free. He's going on, as you can see on the timeline, he had the ablation in 2019. I have his last PSA from this chart was 2023. There's more current. I just saw him last month. He's doing well. And you can see on imaging, there's absolutely no enhancement, no signs of residual disease. And he's had his multiple biopsies showing that there's no cancer on follow-up. So grade group 3 disease, I believe, is a space that we can choose the right patients for treatment. Now, MRI defined visible versus equivocal and negative. This is a pretty good study to give you an understanding. We talk about the genotypic representation in a phenotypic environment. Like, so what are the genes that are driving what things look like? Dr. Klotz is probably going to talk about this as well. I believe you have an MRI visible lesion at 0.2 cc's. You're looking at 27, 30 million cells have to be there to have a 0.2 cc lesion. And MRI is really better at higher volume disease, of course, than low volume disease. I think you look at this and you should be really aware, we're playing with fire, but that's good in cancer, right? We play and we're in a space where we can affect the oncologic outcome. If you have an MRI visible lesion versus an MRI invisible lesion, I think the metastatic potentials may be different. We'll see what Dr. Klotz says about that to me, because some people have argued that there are variants that are not visible on MRI, and every time that happens to me, I'm like, let me see what magnet was done on, what was the technique, what are the patient factors, and those are the challenges we have today. I think what's interesting is marrying MRI with PSMA for risk stratification. That may be something to level the playing field, but also there's poorly differentiated tumors that don't exhibit PSMA. And there's a challenge there too, and we see that as well in our practice. Another study from the Movember International Consortium, just what's important when they're trying to assess risk for patients. If you look, Gleason score, primary, MRI is number 2. And the criteria for PSA density as playing a role, I think it's important to understand that we use PSA density a lot, and we know that patients with higher PSA densities do have a higher risk of failing. I believe this study was shown earlier this morning, but it's a 15-year experience. They have a mean follow-up of 7 years for all the comers. There's 69% failure-free survival. in their cohort was no whole gland therapy, no metastatic systemic or third treatment for focal therapy. And at 7 years, of course, you're going to have a great prostate cancer specific mortality. We know that today that a lot of the cohorts, even out to 15 years, showed no difference. You really have to move out into the 20-30-year margin, 30-year timeline to see some difference in the impact of surgery and treatment. And they did have a 20% retreatment rate in their cohort. But what's nice in their cohort, 90% were intermediate or high risk. So it gives us some understanding of how well focal can do in this large cohort of men. Again, just to go for the pivot trial, there was really no difference between prostatectomy and observation. I believe Dr. Vickers and the group from Memorial just did an analysis of the Bill Alexson and the pivot study, the PROTECT data. I believe they tried to combine that to look at the impact, and they really reinforced active surveillance is ideal. There was a less than 0.5% risk of death with low risk prostate cancer and 3%, I believe, in the grade group 2 disease, 3+4. So you're really seeing that active surveillance maybe should be more utilized, and where should we place our flag in focal therapy? We're kind of edging it down towards more aggressive variants to hopefully impact their oncologic outcomes. These are 2 studies from Memorial just talking about ablation and in-field recurrence. What are we expecting? And the goal, of course, is to have no cancer on the follow-up biopsies. That's similar to Tulsa Pro. I think it's a different vendor for their MRI-guided ultrasound ablation. And they had a 95% success rate at 6 months and 88 at 24 months in their study. And I think these are on the high end of our success rates. And how do we get to higher success rates? I think it really depends on what your baseline data is, how you select the patients, and then how you're following this up. And at our institution, everyone's data is recorded and stored. You can't hide at my institution. You do focal therapy, you do a biopsy, you don't do a good biopsy, we can see that. We know what's happening with everybody, and which is really nice because then you get to learn from your mistakes. This is I believe, the only study or the most recent study comparing focal therapy to radical prostatectomy. And of course, they had favorable and comparable outcomes. Why? Because we know there's not going to be any clinical events in this cohort. But at least tells you, out to 8 years, there is no difference in the failure-free survival when comparing to radical prostatectomy. So again, that's why we're choosing people with a life expectancy greater than 10 years. Hopefully, we can find events that we can prevent, and it's still unclear. Future directions and our research priorities should really focus on improved MRI techniques. We're not there. Yes, we've been doing MRI for, I feel, almost 20 plus years in the prostate space, and it has improved dramatically from where we started, but we still have trouble with interreader variability. I think AI is great, but some people use it as a crutch and may leave things out and miss things, and depends on the algorithm and what it's trained on. These are not transferable from one institution to another because your techniques can change and challenges there. Biomarkers, Amir may have a talk on that later today. No? Was that yesterday? I thought I saw you on talking about biomarkers. So biomarker development, I think, is an important way to risk stratify patients. There's no data in this space to say who's a candidate, who's not, depending on what the biomarkers come back as. But select MDX, ExoDX, I have them. They go from positive to negative post-treatment. Yes, it's an off-label use, but it's still interesting to see that you can change the disease process and inside the patients have a biomarker result. Fusion imaging navigation, I think this is paramount. The days of cognitive treatments should be behind us. Continue to develop new focal therapies and adapted personalized approaches. This is one of my favorite slides. I got this from John Coleman like 8 years ago. But the idea in the transition, we saw all the mistakes we made with VTP, right? Who should be doing focal therapy and low-risk patients with a 30% plus side effect profile in the US? It did not pass the FDA because of that profile, especially in a cohort that is so low risk, and the probability of dying from disease is almost zero. As we look in the focal therapy paradigm where we currently are, where maybe some Gleason 6 are treated, but a majority of that is Gleason 7 disease. And again, here I'm talking about the future possibly, the shift in that paradigm to maybe include clearly identified candidates in the high risk in the high-risk disease. And of course, as we shift from random biopsies to imaging, we're going to have more focal therapy candidates appear. So my thoughts. Clearly, I don't have any facts. I tried to paint a story that the idea that we're moving the field forward to a different space. Safety comes first. Can you identify the right patients? Ruben just went over that, how they review this in tumor board. They go over the imaging. I think it's really important. Check the pathology. My best advice is when people are selecting patients, if you're not sure, repeat the biopsy. Only use your own data that you're sure of. I do not like taking referrals from my partners or anyone else that I feel have not done an adequate biopsy. Be aware patients with high PSA densities have a higher chance of recurrence. Modifications in disease management. So if you're going to do this, you got to follow patients closer. I talked about a PSMA PET at baseline. You're following the PSAs more often. Low threshold to reassess with a PSMA PET CT. So if you had aggressive disease, where is that now? Did you have a negative baseline PSMA PET? Has it changed? Can you explain what's going on? And have a lower threshold to progress to standard treatments because you don't want to burn the oncologic bridge or subject the patient to additional risk if we don't have to. And these are the challenge, I think, as we move the needle into a high-risk cohort. How many people do focal therapy out there in the audience today? How many people treat grade group 4 disease focally? Occasionally, right? You find the right candidates. Do you treat everybody? Absolutely not. High volume, questionable EPE. These are the challenges. These are the ones I stay away from. There are patients, that will ask for things, but I'm not a menu. I'm not McDonald's. You don't get it your way. You get it the right way, hopefully, and that's a challenge we all have as urologists today. So I want to say thank you to everyone for giving me the moment to talk, and I wish you all the best for a great meeting. Dr. Klotz, I got your slides.
So, Dr. Klotz, are you going to make the MR visible now? I hope your slides are visible.
Let's hope. You can bring up the slide deck, hopefully.
Do we have the next speaker? All right.
Okay. We go, okay.
Great. I think we should give him a clap, right?
No, not yet. Wait till I'm done. So, look, we've heard a lot about this whole issue of visibility versus invisibility. There's no question that targeted biopsies miss a significant proportion of what is called clinically significant cancers. And one of the points I'm going to make is that the term clinically significant cancer, really defined as having any elements of Gleason pattern 4 present, is a misconception. And we have to move beyond that. So this is just one systematic review of about 15 trials, systematic versus targeted. The total is on the left in each one of those. The targeted is the middle, the systematic on the right. The message is clear. About 15 or 20% of Gleason grade group 2 or higher are found on systematic and missed on targeted. And this concern about these invisible cancers drives a lot of interventions, and we've heard about that today. Drives systematic biopsies in men having targeted biopsies. It drives systematic biopsies in men with negative imaging. It results in a lot of pushback on the concept of focal therapy. Most patients have multifocal cancers. How can you just treat what you see? And it generates a lot of patient anxiety on active surveillance about what they might have that you don't see on imaging and don't know about. So the question is, why are some cancers invisible? And what is the biologic significance of that? And it turns out a lot of this is radiogenomic data that's just really emerged in the last 3 to 4 years. It actually is, invisibility is a very, very powerful signal. It tells you a lot about the genomics and the natural history of those cancers. It's partly size, so obviously small tumors are less likely to be visible. But it's not just size, it's conspicuity. Conspicuity is a function of primarily the tightness of cellular packing, the loss of the lumen. There are some subtypes that are associated with lower conspicuity. By the way, In my view, it's a myth that cribriform is less likely to be visible. We have our own data that Sangeet Ghai was really responsible for that I think was just published that showed absolutely no difference in a large prospective randomized cohort. But that's another story. But the key point is that the genomics of invisible cancers is dramatically different and more favorable than visible cancers. And the implication is that these invisible cancers are indolent and you don't need to worry about them. So this is a new field of radiogenomics that correlates very close analysis of pixel structure on MRI with gene expression. It involves genomics, transcriptomics, every omics that is in our field has under the rubric of radiogenomics. And it's really exploded in the last few years, and I'm just going to review some of this. This was kind of one of the first, which essentially stratified patients according to grade and visibility versus invisibility. You see on the right some of the gene families that are altered in visible versus invisible, very familiar to those who are in this field: cell cycle regulation, protein folding, hypomethylation, cytoskeleton organization, so on, genes that are involved in cancer aggressivity, invasion, metastasis, and the conclusion, genes involved in cancer progression influence MR visibility. So this is the key point, that the visibility or invisibility is correlated with genes that drive aggressivity. Here's one that looked at, defined this term nimbosis. This comes from UCLA. Nimbosis means nimbus clouds are storm clouds, so a combination of aggressivity both genetically and phenotypically. And there you see SHLAP1 is a well-known prostate cancer-associated gene. PGA is percentage of the genome changed via copy number alteration. Hypoxia-related genes by visibility versus invisibility, PIRADS 1 or 2 versus 5. There's a clear correlation. You can see the predictive value in the area under the curve on the bottom right. Again, nimbosis, or this adverse genetic phenotype, drives MR visibility. Now we're getting to some of the more recent ones. This one's from Scandinavia. There's a lot of information here. I think I'll just go, this is from the same study showing the gene families that are altered and the degree to which they're altered in visible versus invisible. And again, cell cycle checkpoints, mitotic regulation, growth factor signaling, interleukins, DNA methylation. All these familiar genes that we study to predict cancer aggressivity are involved in tumor visibility and visibility. The conclusion, sampling MRI visible lesions with target biopsy should be sufficient for accurate risk stratification because this biomarker of visibility is so powerful. And this one is a proteomic study. Again, the same story here, stratifying by the stromal signature. And again, it's predictive for progression. Higher expression of stroma-related genes in invisible cancer. PFS and BCR correlates with this stromal signature predicting visibility. This one is a transcriptomic study. Again, same story, expression of genes associated with cancer aggressiveness correlates to visibility. So that is a brief overview of about half of the papers, because this is really an embryonic field, but they all show the same thing. The genetic features of invisible cancers are favorable. And then you have some of the clinical data. This is the one that Art just showed, amazing study from Sloan Kettering, 1,449 patients having surgery stratified by visibility versus invisibility. Look at the difference between those curves. Like here is biochemical recurrence. visible versus invisible in the green. The brown is PIRADS 3. Here's mortality, essentially no mortality in the invisible cancers, essentially zero. This is some data from our active surveillance cohort. This is just about to be published. The first thing, so we stratified according to pre-MRI era, post-MRI era, which was 2013. So this is, overall, we had about 3% prostate cancer mortality, one of the higher active surveillance mortalities reported because we were inclusive. But here, stratified by temporal cohort. The red line is since 2013. So since we incorporated MRI formally into our surveillance protocol, we have not had one patient out of, this is about 560, 426 here, but not one patient's developed metastatic disease. In other words, imaging really works in the active surveillance setting. You might say, how could you have 20-year follow-up if you only started using it in 2013, but that's because many of these patients were diagnosed prior to that point and had their MRI in the early, 2012, 2013, so we have longer follow-up. But here's where it gets even more interesting. We've just stratified by visibility versus invisibility. Now, most of the patients had visible cancers. So again, this reflects kind of the early MRI experience. But look at the incredible predictive value of visibility versus invisible. Here's the invisible. 5% of these cases, about 2 out of 40, were upgraded with 10 to 15-year follow-up versus more than half of the patients with PIRADS 4 and 5 and about 1/3 of the patients with PIRADS 3. So this to me is very powerful data that invisible cancers not just are indolent, have a very low rate of being upgraded. And this is the Kaplan-Meier, visible versus invisible. The ones who were upgraded, the 2 patients were upgraded right at the start. Since then, the entire cohorts remain completely stable. And then, of course, the MRI field is evolving rapidly. This is just a short list of 8 different ways that are being worked on to try and better analyze pixel structure. And just to give one example called restriction spectrum imaging, where the ADC shows kind of an equivocal finding. You see this quite clearly on the restricted spectrum imaging. So MRI is getting better. It's another aspect of this whole field that we are just really touching on at this meeting. There's also AI. There's data that AI performs better with in terms of identifying prostate cancer than even experienced radiologists. So to summarize, we know that targeted biopsy misses some cancers, but the evidence is quite strong from the genomic data, from the natural history data, that these invisible cancers are indolent. If they're missed, it doesn't really matter. You follow the patient, you re-image them periodically. If they've got a missed cancer that's actually one of those unusual aggressive ones, it's going to show up over time, almost certainly, because the genes of aggressivity are the genes of visibility. And patients, of course, prefer monitoring with imaging than biopsy, and many advantages in terms of burden of care, cost, the psychological benefits, and so on. So again, I come back to saying we have made a mistake by thinking as soon as there's elements of Gleason 4 that the patient has significant cancer. I think the evidence is if they have invisible cancers, these are indolent. Think about the very favorable natural history of patients with grade group 2. All the surveillance studies show the vast majority of these patients are stable over a 10 to 15-year period. There's a few who progress. Those are the guys with visible cancers. Thank you very much.
Thank you, Laurie. So invisible is indolent. So we should all go back to 1.5 Tesla MR, right? No. in interest of time, can we keep all the questions towards the end? Because you're running behind. Thanks, Laurie.
All right. It's again my honor to introduce Dr. Ukemura. He is a chair of urology at Kyoto since 2015, and since 2023, a vice president at Kyoto Prefecture University. It's an honor because he's the mentor of my mentor, who's sitting in the audience as well. We at USC owe him so much. So thank you very much, Dr. Ukemura.
Thank you. This is a very honor to be here to present given question. That is what I was given is, should I use an MR ultrasound fusion to deploy focal therapy? Of course, answer is yes. So I can start. Sure why. So first of all, principal target of active surveillance should be insignificant, and focal therapy should be significant. And then we should target index cancer among multifocal regions. Already we discussed a lot. Multiparametric MRI visible region is our target. Of course, PZ, TZ cancer may be differently diagnosed. Visibility is the key issues. This is important figure. Currently, PIRATS system have not been recognized as surveillance tool. Maybe PIRATS 0, which suggests disappearance of lesion with clinical response, can be newly defined. That's my personal opinion. But currently, PIRATS system is just a diagnostic initial tool. So our focal therapist needs to develop some important imaging modality to evaluate post-focal therapy status. This is our experience. So before and after, T2 weight suggests disappearance of the lesion. Cellular density suggestive diffusion image, high cellular density disappear, high cellular density area clearly disappear. Enhancement can be no enhanced, enhanced lesion can be no enhanced. For focal therapist, we should do multi-parametric MRI, not biparametric. As you know, as likely as the renal small cell tumor, contrast enhancement disappear is a very important definition of success of focal therapy. That's why I strongly recommend contrast enhancement is an important technique for follow-up. This no appearance, no enhancement is an important definition in the future for focal therapy. So for this, actually MRI ability. But in practice, MRI ultrasound fusion system is a diagnostic tool. As for focal therapy, very important technique so that to identify the location and the characteristics of the index region should be confirmed MRI ultrasound fusion, not only diagnostic but also intraoperative and postoperative. My favorable technique of MRI ultrasound fusion is this system to use 3D real-time ultrasound probe. The philosophy, how important of this is this 3D ultrasound can achieve to acquire 3D volume data of prostate every single time. As you know, MRI and CT is very popular and reliable for every doctor because of it show 3D volume data of the body. Now, ultrasound also have an important technique to define 3D digitalized volume data, which can be image fused to 3D volume data of MRI. MRI and ultrasound can be used not only first look biopsy, but also second look ablation biopsy. This image fusion technique is important not only diagnostic, but also surveillance, and of course, at intraoperatively. Key technology of image fusion is precise targeting of the visible prostate cancer and revisiting intraoperatively and follow-up biopsy. This is our proposal of second look precise repeat second look biopsy. We record every single location of the systemic biopsy when T1C cancer. This red arrow demonstrates the positive cancer biopsy. 1 year later, we can revisit the same spot so that this time 5 target biopsies are positive, which means target the positive cancer trajectory. Another proposal of mine is targeted field biopsy, which is named by myself. First look biopsy can be, 12 cores can be negative, but second surveillance biopsy, if same position can be biopsied, 12 plus 12 is only 12. But if unsampled field can be targeted, 12 plus 12 means 24 saturation biopsy. Location is so important for our focal therapist. So, in surveillance biopsy set from unsampled process field in which the previous biopsy was negative, second look target field biopsy plus negative first look systematic biopsy can be equal to 24 saturation biopsy set. Now, intraoperative fusion, how it's important I can tell. First, 3D MRI target location can be fused intraoperative targeting. Second, past biopsy 3D ultrasound, that means cancer positive biopsy trajectory, can be fused intraoperatively and revisit. Third, 3D ultrasound itself can be 3D ultrasound fused. So this is the positive cancer core from the transrectal biopsy to target lesion, and intraoperatively, transperineally, cryoprobe can be placed. Not only cancer visible MRI visible lesion, but also biopsy positive core can be suggested the targeted area, which can be peri-regional safety margin area, so that this area should be covered to think about peri-regional positive biopsy. And then fusion system can suggest how important, how precisely to target the MRI region. This interoperable navigation system of 3D real-time ultrasound image, as long as using a 3D ultrasound image, MRI volume data can be fused with real-time 3D ultrasound volume data. And then image fusion system allows us augmented reality interoperable confirmation of lethal area can be covered entire targeted region like this. As you know, cryoablation need minus 40 degrees Celsius all of the cancer within 5 millimeters inside of the ice ball margin. This blue line suggests the minus 40 degrees Celsius lethal temperature area, and light blue suggests 0 degree ice ball margin. Therefore, all cancer lesions should be within this dark blue area. And then this kind of three cryoneedles estimated ice ball complex can be overlaid with intraoperative image fusion tool. Another view, bird view, we can confirm how precisely targeted with these 3D cryoprobe estimated ice ball fusion area. So same thing. Targeted MRI visible region should be inside lethal temperature zone. So intraoperatively, we of course combined Doppler ultrasound and real-time placement should be monitored by plain transrectal ultrasound, and the ice ball should be real-timely monitored to confirm accuracy of the treatment as well as the safety. Recently, we introduced not only the cryo, but also the microwaves using this device. This device allows us the needle tip 20 millimeter in length, 6 millimeter radius. This rugby ball-like area can be coagulated and into the necrosis. So this is the example. MRI lesion can be visualized by Doppler ultrasound like this clearly, axial and sagittal scan, and then this can be real-timely targeted by the microwave needle, and intraoperatively microbubble can be generated so that treated area can be monitored intraoperatively real-timely. This case dropped the PSA down immediately 1 month after the surgery within PSA 4 or less. Sorry, this is Japanese. Ejaculation and erection and no incontinence, this means. So, in the microwave, different from the cryoprobe, we need one by one monitoring is needed. So first needle can be placed here. Second needle and the third needle placed like this. And every single time, these should be image fused and confirm the precision of placement. Without 3D real-time ultrasound volume data with previous 3D ultrasound image data, this cannot be achieved. Definitely, we need image fusion system intraoperatively. To deploy focal therapy, especially microwave treatment, image fusion system is essential. Another case, first one, second one, third one. Then fourth one, fifth one, sixth one. Distal and proximal 2 times were generated. That means almost 30 millimeter length of the ablative area can be combined, so that using image fusion system, we confirm entire index region can be destroyed. Another case, this area, 5 times and 3 times destroy can be image fused, so that confirm entire cancer region can be destroyed. Finally, this is a concept of focal therapy. This index region can be focal therapy treated, the PSA down. Untreated area, there is some insignificant cancer can be exist, but PSA up above 4, in my experience, above PSA 4, MRI likely visualize the index region like this, and when we repeat focal therapy. At this point, the MRI of this and the MRI of this, these images can be fused so that confirm treated area and also new area. Thank you for your attention for my lecture.
Thank you, Prof. So, yeah. So we'll move on to our last speaker, Professor Shoji Sunao, fellow hyphoologist. We have to start using new terms, cryologist and hyphoologist maybe. And so just a brief introduction, he's the professor and chairman of the Department of Urology at Tokai University School of Medicine and director of the Robotic Assisted Surgery Center of Tokai University. And he has performed 1,800 MRI transfusion image-guided prostate biopsies and about 450 focal therapy procedures with HIFU for the treatment of prostate cancer. Well renowned. The stage is yours, Professor.
Thank you very much. Great opportunity, Professor Jack. Thank you very much. I would like to start my presentation. This is my COI. So is there true focal therapy, hemiablation versus regional ablation? It is challenging to directly compare the clinical outcomes of hemiablation and regional ablation. However, based on general knowledge of some studies, so regional ablation is suggested to be superior in terms of having fewer side effects and improving quality of life. So in my presentation, I would like to demonstrate the benefit and challenges of performing regional ablation. This is today's agenda of my presentation. So impact of the treatment area on function in focal therapy. In the present study, we analyze the risk factors for the occurrence of urinary dysfunction after focal therapy with HIFU in 90 patients with localized prostate cancer. Of the clinical factors, such as age, PSA, prostate volume, prostate treated volume, and total treatment energy, and pre-procedural maximum flow rate and treatment region, So there was a great risk of urinary dysfunction with treatment in the bilateral anterior transition portion than in the other portion during focus therapy with HIFU. So urinary function significantly deteriorated at 1 month post-treatment in the anterior transition zone group compared to the posterior transition zone and or peripheral zone group. However, by 3 months after treatment, urinary functions in both groups improved to baseline level, showing no significantly different. In the study, we analyzed the risk factors for the occurrence of severe erectile dysfunction after focus therapy with HIFU in 92 patients with localized prostate cancer. Of the clinical factors such as age, PSA, T-stage, pre-procedural IIF5, and procedural sexual domain of EPIC and treatment location. So the pre-procedural lower score of IIF5 and sexual domain of EPICs and treatment of the edge of the peripheral zone in proximity to neurovascular bundle were risk factors for the severe erectile dysfunction. Between the patient treated with and without the edge of the peripheral zone in proximity to the neurovascular bundle, IIF5 and sexual domain of EPICs were significantly different at 12 months after treatment. These studies have shown that there were areas which impact function in focal therapy. And based on these results, preserving the lesions that affect function may contribute to improved functional outcome in focal therapy. Next, considerations and perspective in performing regional ablation. How much margin is necessary for the regional ablation? Previous studies that compared multiparametric MRI and radical prostatectomy specimens in 114 patients found tumor diameter was underestimated by an average of 11 millimeter on teeth-weighted image compared with tumor diagnosis diameters on foreground pathology. In other study, average underestimation of histological tumor volume by MRI is 5.9% and constant throughout the measurement range. So based on these studies, prostate volume reportedly tend to be underestimated by teeth-weighted image. And there is a potential risk to leaving residual cancer cells due to the reduced treatment area. So it is recommended that to treat an area extending beyond the 5 millimeter safety margin from the edge of the lesions visualized on MRI. So in the protocol, a multi-center prospective study on focal therapy with HIFU in Japan, for the patient with MRI visible lesion, so regional ablation has been treated. However, for the patient with MRI invisible significant cancer, the ablation has been performed. However, recently some reporting that biopsy using PSMA can more accuracy location of the cancer and improve the detection rate of clinically significant cancer compared with MRI-guided biopsy. The diagnosis using PSM PET has a potential to become modality that support regional ablation in focal therapy. So last, introduction to the actual procedure of regional ablation. So procedure of regional ablation consists of identification and localization of significant cancer, treatment planning, and real-time monitoring. So I would like to introduce our clinical result of a multi-institutional study of focal therapy using HIFU in Japan. So this is an inclusion criteria. So can I move the movie? So to decide the treatment range and 3D location, okay. So location and the relation, it's relation to the interprostatic structure was analyzed using the software. Okay. Okay. Please, next presentation. Yeah. So focal ablation was performed based on the 3D location of the significant cancer with a margin. So in a protocol, prostate was partitioned to the 12 regions in apex and base side based on ultrasound contour of TZ and PZ and wrestler. Focal ablation was applied by partitions area. In technical development on focal therapy with HIFE, in a clinical experience of foreground HIFE, prostate swelling was intraoperatively observed on real-time TRAS monitoring. This image is a TRAS image of the prostate before the treatment. And this is a same prostate ultrasound image after treatment for anterior zone. So we measure the change of the prostate volume and interprostatic point shift before and after treatment in 44 patients. So during the treatment for anterior portion with median 24 minute treatment, the median swelling was 18% and median shift was 3.7%, 3.7 millimeter. So how can we control interprostatal prostate edema for the accurate focal therapy? So we came up with compression stocking for edema. So we started to compress the prostate from the rectum by the HIFE probe interprocedurally, so-called compression method. So in compression method, the balloon was expanded by the water from 80 to 200 millimeter. So this is a picture of the conventional method and the compression method. So the compression method significantly suppressed prostate swelling and shift during the HIFE. On contrast, enhanced MRI at 2 weeks after the foreground HIFE, and so blood flow was remained in anterior portion in conventional method. However, all blood flow was disappeared in compression method. I show you the clinical result of foreground HIFE at our institution. Between the patient treated with HIFE with and without the compression method, biochemical disease-free survival rate was significantly different in low, intermediate, and high-risk groups. So now we have introduced the compression method to regional ablation in our institution. That output power was adjusted to be observed hyperechoic region, so-called popcorn phenomena. This slide shows our clinical result of the focal therapy. These are patient characteristics. This is the background of the patient. The number of the patient in low, intermediate, and high risk were 51, 107, and 82 patients. In oncological outcomes, the pathological recurrence in low, intermediate, and high risk group were 7.8, 8.4, and 8.5% respectively, and there was no recurrence around the treated area. So please start the video. So recently, newly fusion cyst was introduced to the newly devices. I introduced the Sonoblade fusion system. So I'm doing the fusion biopsy. This is a 3D location of the significant cancer. Next, preparation for HIFE treatment. This is a HIFE probe. This is a transducer. in spherical transducer. So imaging and treatment transducer were introduced. And I insert the probe and fix the probe and get the translated ultrasound image. So like this, so from the apex to base, we get the 3D model of the prostate using the ultrasound. This is a fusion image. So based on this fusion image, so we can decide the treatment area like this. Okay. So finally, I'd like to introduce biomarker for the evaluation of treatment effect of focal therapy. So we focused on the differences in the sugar chain of PSA between normal and cancerous prostate tissue. LDN PSA is a PSA carrying a prostate cancer associated sugar chain. So positive correlation was found between the Gleason score of the index lesion and LDN PSA tumor volume density. So using the cutoff value of LDN PSA density, 83% of the patients who were diagnosed with pathological recurrence at median 20 months after treatment were already predicted to develop this pathological recurrence at 3 months after treatment. So biomarker has potentially utility in predicting residual significant cancer after regional ablation, allowing for early diagnosis. This is my conclusion. Based on general knowledge of and some studies, regional ablation is suggested to be superior in terms of having fewer side effects and improving quality of life. However, it is important to be aware that regional ablation, if not performed with sufficient margins, may leave residual cancer. PSA PET has the potential to enhance the accuracy of regional ablation. Recent advancement in treatment technique and technologies are driving the progress of regional ablation. Thank you very much.
Should we invite all of the speakers?
Yep, can we have all the speakers up on stage? And we'll have a quick Q&A session in the interest of time.
I have a few questions. I think Dr. Klotz left. Great. All right. Any questions? I have a question to start with Dr. Rastinahat. So it was a great talk. And when you talked about grade group 4, the question I always have when I counsel patients, if you have one core of grade group 4, meaning Gleason 8, and in the penumbra there's all Gleason 3+3, is your discussion going to be the same as someone who only had grade group 4 on all the biopsies, or is that by definition, if around there's some pattern 3, is the patient downgraded to 4+3, I would say, at the highest?
If you're referring to in the lesion, I think there's some sampling issues itself, right? If you have a small 1 to 2 millimeters of grade group 4 disease and the rest is pattern 2 or pattern 1, there's a sampling issue going on. And I think you could have a better understanding that it's probably a lower risk disease because what you hit, especially the less than 1 millimeter, the 0.5 millimeters of grade group 4, that is, in my mind, definitely a sampling issue. And I would look at that as probably a lower or biologically less aggressive disease than what's showing up on the path report.
Yeah. Right.
So I've got a question for Professor Shoji. Yep. So it looks like focal therapy is globally going to probably become standard of care at some point. And how far are we at considering focal therapy for high risk, Gleason 5, for that matter? And will there be a role for neoadjuvant treatment, but with focal therapy?
Yes, maybe so. Gleason pattern 5 is very, very difficult to treat by focal therapy, but Gleason pattern 4 with a small region would be a target for focal therapy. So the professor already presented. So I agree completely. So imaging supporting is very important, and biopsy technique very important too. So by the development of both of the technologies, the focal therapy range would be widespread. Yeah.
Very special case for the salvage. Gleason's grade maybe not the issues. We can locally control at the salvage status, even the highest Gleason score.
I typically will salvage focal hemigland ablation. I do a larger margin in the cohorts of post-radiation failure, and I think it's completely reasonable. I do think different modalities then start to play a role in what you choose. I don't want to be modality specific, but I do have my favorites when doing salvage, and I think there's strong data to support that if there's skip lesions, you run a higher risk of recurrence, so you have to choose your modality that you feel comfortable with, and that also gives you the most homogeneous ablation. Dr. Jack Tay, question?
Yeah, thanks. I really put you guys together because I had this question for myself. So how much grade group 4 should we be pushing? I mean, like, I guess a question for all the panelists and the moderators, would you treat 4+3 with focal therapy if it was isolated in one lesion and ablatable, or would you think that you would counsel the patient otherwise? And do you think that there's a difference between, like, say, a 4+3 lesion and perhaps MRI invisible 3+3 elsewhere in the gland? Would you treat that?
Well, me,
Yeah.
4+3 is, I always say, my favorite disease to treat, because the less aggressive it is, I think I watch a lot of patients with 3+4, although I treat them with focal as well. Contralateral grade 1 part of our consensus is not a contraindication for focal therapy, but I always say the more pattern 4 I have, the better I feel treating, because I think, number one, talking about MRI visibility, the more pattern 4 you have, it's also more focal. I feel like if a more pattern, it's a Gleason grade group 3, I think it's more a chronic disease. So Gleason 6 is a more chronic disease, in my opinion. I don't know what others think.
Our inclusion criteria is large volume of Gleason 6, Gleason 7 all-comer, small volume of Gleason 8 at the initial primary.
Basically everyone. I have a question for Dr. Okimura. I think your talk was really fantastic. When you were talking about in renal cancer, when we ablate renal lesions, we follow with contrast enhanced. That's the definition of treatment success. Are we too critical that we, when it comes to the prostate, that we biopsy everyone? Like in my case, great PSA response, over 90% down, MRI is negative. I then decide to get a PSM and PET scan, everything negative. I still biopsy the patient just for documentation purposes, maybe research, but are we too critical?
You mean in terms of contrast?
Yeah.
His endpoint.
The endpoint. So I ablated the patient, get an MRI a year later, no enhancement, and then we're going to get a PSM and PET scan, also negative. PSA came down, but we still at least I still biopsy the patient. But in renal cancer, we don't do all this. We say there's no contrast enhanced, he's cured.
Yes. In clinical trial, biopsy is set up the mandatory. But real world of surveillance of focal therapy, our indication of the surveillance biopsy is MRI and PSA if required.
Okay, so thank you very much for the real-world answer. Chairman has spoken. We have to go on to the panel.
Man, I had so much to say. Watch out for your radiologists. They're trying to get rid of DCE. I think it's a really healthy endpoint, and you should keep an eye on your radiologist in this space. And, there's level 1 evidence that there's parity with renal mass ablation, and we're all here talking about focal therapy in a way that we've already had the foregone conclusion that it works. I think that's amazing how far we've come as a society, as people, so let's all keep it up. And we'll move on to the next section, Dr. Tay.
Thank you very much, and let's give them a big round of applause.
So I think the next session is going to be a debate. We're going to have the moderators on stage, Dr. Rastina Hurt, Dr. Edmund Cheong. And we do have one more moderator, right? Dr. Andre Abro. Yes. This is going to be a crossfire debate, and unfortunately, it's going to be Dr. Tan Wei Pin, which is always a champion in debates, versus Dr. Ruben Olivares. But unfortunately, Dr. Olivares had his flight turned back, so he couldn't make it. Yeah, he's supposed to debate no to focal therapy. So I don't know whether this constitutes a walkover, but he's got a video to present. Do you want to go first and have his video next? I'm going to let you guys run this.
Hello. Okay, so we are next in the section of the debate, and it gives me great pleasure to introduce the first speaker of the debate. Professor Tan Wei Fin is an assistant professor of urology and urologic oncologist at the Tisch University, New York, University Logan Health in New York City. He completed his training at Rush University Medical Center and his uro-oncology fellowship at Duke University. So I think Professor Tan is going to tell us his stance on yes for focal therapy. So Professor Tan, please.
Thank you for the invitation to debate, Ruben. As we know, if you don't show up for the debate, that constitutes as a loss straight out. Basically, Ruben loses. But I'm still going to try and make a case on why there is, focal therapy is here to stay. I have no financial disclosure. So once again, I want to highlight that today we're debating intermediate risk disease only. We're not talking about high risk or low risk. So basically, grade group 2 and 3, essentially. When we look at radical therapy for prostate cancer, we do know that looking at 3 randomized trials, there has not been any overall survival benefit when it comes to radical therapy so far. So we know that perhaps we're being a little bit too aggressive about treating patients with prostate cancer as a whole. And that's important because many of these trials, many of these radical therapies that we perform on patients actually do have a lot of side effects. So we do know that throughout, based on the past 50 years or so, we know that prostate cancer has come a long way. When we look at how many of this treatment has actually became the standard of care, there actually hasn't been much evidence pertaining to that. We know that surgery and radiation and whole gland cryotherapy was kind of grandfathered in to become the standard of care for prostate cancer. When they were grandfathered in, there actually wasn't much data pertaining to any of this therapy. And if we actually looked at radiation therapy, back then when there wasn't much data, it would definitely not make candidacy as the standard of care these days. So whenever they have this argument that focal therapies shouldn't be the standard of care, if we look back at how radiation therapy came about, they definitely wouldn't make criteria. They wouldn't be the standard of care. We know that in general, low-risk patients, we're going to watch them. High-risk patients, you can probably perform focal therapy in select patients, but most of them are going to end up with whole gland therapy, which is either radiation or surgery. The intermediate risk group, that's the sweet spot on where focal therapy comes in. The ideal patient, which is what we're debating today, unilateral disease, MRI visible, low volume disease that's isolated from many critical structures like the urethra, the sphincter, and whatnot. Absence of high-risk features, that's the sweet spot on where we're going to debate on whether it makes sense to do focal therapy. We're not going to talk about the energy modality because at the end of the day, it's dealer's choice. If you do more of it, if you're good at specific energy modality, that's probably what's going to work. But posteriorly, in general, those are probably better candidates for HIFU in general. You can still do cryo, IRE, and PDT on those, but usually cryotherapy and IRE would be, patients with anterior tumor. Those patients they're good candidates for those therapy. If you have large volume disease, bilateral disease, perhaps they should just get radical therapy. When we look at the survival data in the PROTECT trial, which was recently published in the New England Journal of Medicine, this is 15-year data. 15-year data, and you look at the entire cohort. They were randomized to surgery, radiation, and active surveillance. This cohort, when you look at the disease-free survival at 15 years, right? Well, if you look at the metastasis rate in the active surveillance cohort, that was double of the patients who underwent surgery and radiation. But when you look at the number of patients that actually died of prostate cancer at 15 years, in the active surveillance cohort, it was less than 1% difference compared to the radical prostatectomy and active surveillance cohort. So we do know that perhaps we're being a little too aggressive about treating people with radical therapy. When you look at the functional outcome data, as much as we make fun of the British for not doing good surgery and whatnot, at the end of the day, perhaps we pad our data in America. 25% of patients require one or more pad post-prostatectomy. That's pretty high. This is the data at 10 years. That shows that a lot of times when we publish our massaged retrospective cohort, we are underestimating the morbidity that we actually, cause patients. When we look at the 11-year data post-radiation in the PROTECT trial, 20% of patients had one episode of stool incontinence at least once a week. That's pretty high. Nobody wants to crap their pants. When we look at the functional outcomes in terms of erectile dysfunction, 18% of patients in the post-prostatectomy cohort were able to achieve an erection firm enough for intercourse. That's terrible. So we know that we do a lot of harms to patients as urologists. The key point of PROTECT is that 1/3 of these patients actually had intermediate and high-risk disease. So it's not just Gleason 6 that we say probably shouldn't be treated these days. This is real disease in some of these patients. The primary endpoint showed less than 1% overall survival difference, prostate cancer survival difference at 15 years, which is extremely low. So, we should try to de-escalate what we're offering patients, especially if they are good candidates for another form of therapy, because we do know that prostatectomy and radiation have significant functional impact. When we look at the regret data, this is out of Vanderbilt. It shows that patients who underwent a radical prostatectomy had the highest regret compared to any other group. 16% in the radical prostatectomy group compared to 11% in the radiotherapy group. And active surveillance actually had the least number of regret. So why focal therapy, right? Well, because there's been overdiagnosis and overtreatment for prostate cancer, especially in America. I do think depending on where we are, for example, in Malaysia, the number of patients with metastatic prostate cancer at diagnosis is about 50%. So, screening is definitely more important and we need to screen more patients there. But in America, where we're overtreating patients, focal therapy is definitely here to stay, right? So on one hand, we have radical therapy. On the other hand, we have active surveillance. Focal therapy is the middle ground. It's here to be in the middle because, in the radical treatment group, we do cause bad things to patients. They're incontinent, impotent, rectal toxicity, and overtreatment as a whole. Whereas in the active surveillance group, we do nothing about it. Obviously, the cancer is going to progress, especially if it's clinically significant prostate cancer. So the middle ground is focal therapy. When I was at Duke with Tom Polasek, we looked at our data there. And the failure-free survival at 5 years was 75%. So remember, it's important to look at the definition on how we define our success when it comes to focal therapy. Failure-free survival means that they were essentially biopsied, and if there is recurrence, then basically they failed. If we looked at the erectile function data and partial gland cryoablation, this is the Duke data, essentially it shows that patients who got focal cryo had better erections than patients who had hemicryo versus subtotal cryoablations. So the red line depicts patients who underwent focal cryo. When we look at the urinary symptoms, we found that patients who we ablated more, meaning the subtotal cryo, actually had a larger improvement in urinary function. Looking at the NYU data, this was published in the Journal of Urology a few years ago. Essentially, it showed that our 3-year failure-free survival, our inferior occurrence at 3 years, meaning these patients were biopsied, we had a 3% inferior occurrence. Recently we updated this at the most recent AUA. It's important to highlight a few things here. So this is our 5-year oncological outcome. If you look at the mean age of patients, they were 65. So we're not doing focal therapy on patients who are just, on the older extent of, of their life. We're doing it on young patients as well. If you look at the mean PSA, it's 6.9. It's important to note that these are patients with grade group 2 or 3 disease, which is essentially, clinically significant prostate cancer. 30% of our cohort had grade group 3 disease. And when we look at our data, the inferior occurrence rate was 12% at 5 years, and the out of furor occurrence rate was 25% at 5 years, which is similar to the Duke data. And this is only patients with real cancer. That's what we're debating today. Now, there's similar data from the Martini Clinic pertaining to HIFU. This was also presented at the AUA. They showed that their 5-year HIFU inferior occurrence rate was 7.3%, and the out of furor occurrence rate was 10.9%. So I think there are a few important things to note there. The NYU data, all of these patients with 5-year follow-up, we had a mean PSA, the number of PSAs that were obtained were 10. That means that they essentially got a PSA once every 6 months. The number of MRIs obtained in our cohort was 3.6 at 5 years. That means they had 3.6 MRI on average at 5 years. And the number of biopsies that was performed on them was 2.2. So all of our patients that we presented, in the NYU group was essentially biopsy confirmed to be negative. It's also important to note that all of them enrolled into a trial prior to being treated with focal therapy. Essentially, they all signed a consent and they enroll into a prospective database, which we don't control, so that there is less bias there. We have 2 or 3 full-time database manager that basically inputs all of our data. So it's very clean data when it comes to that. At the end of the day, focal therapy is not here to replace radical therapy in any way. We need more personalized treatment. Patients who are candidates for it perhaps should undergo focal therapy, but there are many patients who are not candidates for it, right? Education is key. Patient needs to be aware of, when we can perform focal therapy with good success. At the end of the day, we should treat the patient, because a lot of prostate cancer care comes down to patient decision making. At the end of the day, what's important to them is what we are planning to address, and everyone's priority is very different. I do believe that there is no one size fits all, but in the perfect patient for focal therapy, absolutely, focal therapy is here to stay. Thank you.
Hello. I'd like to introduce our second debater. He'll be playing his video. Unfortunately, he's a victim of the CrowdStrike bug from Delta. This is Ruben Olivares. He's a surgeon associate professor of urology at the Cleveland Clinic, Lerner College of Medicine at Case Western Reserve University. He specializes in minimally invasive treatments for urologic oncology and is a prominent figure in the field of focal therapy for the treatment of localized prostate cancer. Thank you. Ruben, please present. The video, please. Is there audio or?
I'm Dr. Ruben Olivares. I'm urologist and focal therapy program lead at Cleveland Clinic. We will debate today an easy case, why there is no enough evidence for focal treatment as considered standard treatment option for intermediate prostate cancer. This is my conflict of interest page. So first, if we ask AI where there is enough evidence or not, we can see a clearly nice summary where there is no enough evidence to be considered a standard treatment. The bottom line that we have a lot of work to do. The same information comes from our current guidelines, with AUA clearly state that for intermediate prostate cancer, either favorable or unfavorable, active surveillance in selected cases or radical prostatectomy or radiotherapy are the standard option that should be offered. And that statement comes from a lot of body of evidence, a lot of randomized controlled trials. For example, here we have the PROTECT trial that we all well know that demonstrate 50% in reduction of metastases with radical treatment. Using those reports, we should agree that radical prostatectomy or radiotherapy are highly likely curative in patients with localized intermediate prostate cancer. After the surgery, we will have a complete clarity on the cancer status, given that the follow-up is straightforward. The PSA should be undetectable. The morbidity using those approach are there, we all know, but we can talk the patient before that happens, so we can make a plan to try to fix that. During the follow-up, there is no need to repeat imaging or more biopsies. Dr. Donovan, using the same cohort of patients for the PROTECT trial, demonstrate that there is the downside of those options are the potential deterioration of the quality of life given the occurrence of urine leakage or erectile dysfunction. And that, unfortunately, that kind of complication are even worse with the longer follow-up. That's why we need to do something. Improvement in the treatment for prostate cancer are imperative. So the improvement for prostate cancer management can come from the focal therapy. That's why we are all here. And do multiple factors contribute to the feasibility of focal treatment? Prostate cancer is now detected early due to PSA screening, so we are diagnosing patients at early stage. There is an improvement in understanding of the prostate cancer biology and the significance of the index lesion that will drive the potential metastatic spread. There are been advancement in prostate MRI, so now we have a more accurate staging and localization of the cancer. We can use that imaging information, taking better biopsy using the new Fusion platform for prostate biopsy. So now we can use the biopsy tract localization as a mapping to deliver a tailored focal treatment. There are new source of energy, so we can now use different energy based especially in the patient characteristic and the tumor location. The main principle that we have to follow to deliver focal treatment is a good patient selection, a clear patient follow-up, because we must all agree that we are very good to offer PSA, MRI, more biopsy to do the right diagnosis, but we have to deliver the same precision during the follow-up to actively look for the potential reoccurrence of the cancer. And the third one is the treatment approach. We all know the similarity with the journey that the surgeon treating breast cancer did, from the Halsted mastectomy to the development of the modified radical mastectomy to try to improve and reduce the comorbidity of the more radical treatment, and currently the widespread utilization of the partial mastectomy. We can put together in parallel two lines. On the top, the line that for the journey with the focal therapy for breast cancer from the pioneers, early adopters, and a lot of well-designed randomized control trials that demonstrate, the feasibility of focal treatment for breast cancer. In the bottom line is the focal therapy for prostate cancer. On the left, we have the early adopters. Many of them are sitting in the auditorium right now. After that, early adopters. And I would say that we are now in this location with some ongoing randomized control trials. This is the paper from Dr. Abreu reporting that we are seeing more and more reports of focal treatment for prostate cancer. Unfortunately, many of them are ideal classification stage 1 or 2, and just 1% are ideal stage 4. Dr. Rodriguez Sanchez in the recent Falcon consensus just highlight how difficult is the standardization when we cannot agree in which patient we are going to offer focal treatment. After a few rounds, there is no agreement if a patient unfortunately dealing with grade group 3 prostate cancer should receive focal treatment. In our own experience at Cleveland Clinic, we have our weekly focal therapy tumor board, and we have to face, the problems of the tools that we are currently using to diagnose patients suitable for focal treatment. For example, just doing the path review, 40% of the patients, especially those who came to the discussion with unilateral small volume grade group 2 prostate cancer, the sweet spot for focal treatment, were downgraded to grade group 1, so active surveillance was the right recommendation. What about the MRI? This is a confusion matrix that demonstrates the MRI first read on the left with the MRI overread just using the eyes of focal treatment. In the perfect world, all the patients should fall in the green light, but unfortunately, we can see that many of them, after the MRI overread, had lesion outside or lesion concerning of more aggressive behavior, so we have to do more workup or probably more biopsy. The way that we have been tackled this problem, unfortunately, is not the best one, using consensus. And I found at least 8 Delphi consensus reported since 2014 to try to help with definitions, nomenclature, patient selection, source of energy, follow-up. But with the randomized control trials, we can see the same lack of standardization. So even though we can design knowing all the difficulty to do that, unfortunately, some of them are going to treat patients with a PSA more than 20, up to 20, some of them up to 15. Some of them are treating grade group 3 prostate cancer, especially from the UK. Many places of Europe are treating up to grade group 2. I just want to highlight that in the current randomized control trial that we are, recruiting patients, there is no standardization. So I have prepared a few questions for my opponent, Dr. Weeping Tan, and I'm sure he will have, a lot of problem to answer that because we have not ready to answer those questions. For example, we are seeing more and more MRI, and the MRI demonstrate the potential extraprostatic extension. We are going to treat those patients just with the MRI demonstrate gross EPE. We need a new classification about EPE on the MRI. Secondly, about the path biopsy, what are the implications of the adverse feature, for example, cribriform pattern, how it's going to change the management for either patient on active surveillance or the patient looking for focal treatment? What will be the minimal treatment extension, knowing the margin safety is needed to improve oncological outcomes. So it looks like we are not offered focal treatment anymore. We are using more hemiablation or quadrant ablation. How we are going to define PSA failure. We are seeing more and more utilization of PSMA PET-CT. What is going to be the current role in the focal therapy field? After he's done with all those questions, we can start with all the rest. So probably we are going to spend, a good time today try to answer all those uncertainties. In conclusion, over the recent years, 72 studies on focal treatment has been conducted and published. Among them, only 2 randomized control trials and only 2 propensity score match analyses. Most of the study on focal treatment are heterogeneous and still in an early research stage. Given the long-term survival of patients with localized prostate cancer and the difficulty designing randomized control trials, we should aim at least for a standardization of our registries. In 2024, additional work is necessary to assert the role of focal treatment in the armamentarium for treatment of localized prostate cancer. Thank you.
I would like first to thank the debaters. Great job. Dr. Olivares, I think halfway through his talk, it appeared that he was endorsing focal therapy. It's really a challenge to walk away from that. Dr. Tan, could you please comment on his one fact that he said surgery had a 50% reduction in metastatic incidences in the PIVOT or PROTECT trial? How many patients out of 100 would that be if you actually did surgery on them? Is there actually a benefit? And can you please tell us about that? Because he said 50%.
When we look at a trial, it's very important to look at the absolute difference versus the relative difference, because you can always massage data to make it show what you want it to be. You look at the, what he said was relative difference essentially. And if you look at that, as my slides pointed out, less than 1% survival difference. If you do the math, it's very simple. You take 1 and you divide by 2. Essentially, that's what relative difference is. So he's trying to make a case. He's trying to blindside the audience and show that, he's trying to mislead with all this misinformation going out there. But the truth of the matter is the absolute difference is less than 1%.
Dr. Tan, thank you for your talk. And, it appears that Professor Olivares has fired the first salvo despite being not here of all the questions, multiple questions he's asked. But I think overall impression is that it's good that this meeting is held here in Singapore, because I think in our region, outside the people here involved, except for Dr. T.K. Jack, the rest of the urologists here in this region still needs a lot of convincing to move on to focal therapy. So, and for those of us who do prostatectomy, we are sometimes hit by the fact that the pathology comes back as higher grade than what was seen at the intermediate risk when we first do the prostatectomy for. So is there any, in your argument, in your thoughts, is there any caveats, for example, what Professor Olivares showed in MRI showing possible EPE, are there any caveats that would prevent you from doing focal therapy? And do you do saturation or mapping biopsies for everybody to determine that pre-treatment?
All good questions. So I don't think ECE excludes someone from undergoing focal therapy, but at the end of the day, it really comes down to the overall clinical picture. There are many things that would go into account on, towards that. At the end of the day, I do think because focal therapy is in its infancy, it is very important that we need to make sure we're doing a good job to actually show that it works. For example, if a patient underwent a biopsy that was not done by me, and they end up coming to see me for a consultation, almost always they will have that biopsy repeated. The MRI will be reread at NYU, and then the patient would have to undergo another biopsy, because to me, if you're not the one doing the biopsy and you're not mapping it out accordingly, it makes no sense for you to be the one doing focal therapy. There's so many factors that go into account on how accurate the biopsy is. Whether it's a fixed arm, whether it's a freehand device, whether it's cognition, whether it's fusion. There's so many platforms out there, and the person doing focal therapy ultimately has to be the guy doing the biopsy, because you're gonna follow these patients as well. It's not a one and done procedure. At the end of the day, they need to be followed, they need to be re-biopsied until you have proven that your recurrence rate is extremely low. And then even then, it's a debate on whether imaging itself is enough to replace a biopsy. So in our initial experience, we biopsied everyone. When a patient comes in, I tell them that within 5 years, expect to have 2 or 3 biopsies. And if that's not okay with you, at the end of the day, maybe focal therapy is not for you. Focal therapy, it's to de-escalate prostate cancer care, where these patients actually, end up kind of being on active surveillance when they are previously not candidates for active surveillance. In terms of the question on whether everyone gets a saturation biopsy, I think it's very subjective. Sometimes it's easier to convince a patient to undergo a saturation biopsy if they've had a biopsy elsewhere. One of my partners, Jim Wysong, would do a saturation biopsy on everyone. If you do that, yes, your recurrence rate is probably going to be slightly lower. But I personally do not do a saturation biopsy on everyone. Prior to starting our focal therapy program, we published a study in 2015 where 100 patients underwent whole mount segmentation from a pathological standpoint. And we found that the margin that you need to treat is 0.9 centimeters from the index lesion on the MRI. Since then, that has kind of become the standard of care worldwide, where most people use a 1 centimeter margin. And I think that probably is one of the reasons why we get such good result from our focal therapy, where our inferior recurrence rate is extremely low. It's because all of us almost always will treat up to 1 centimeter from the index lesion.
Thank you, Dr. Tan.
Yeah.
Dr. Tay, you have a question?
Thanks so much. I have a couple of comments just to respond to Dr. Edmund Cheong. Dr. Edmund Cheong is one of the greats in prostate cancer in Singapore. He leads urology in the other hospital, so it's kind of important that I convince him to do focal therapy as well, so that we can have a true multi-center. And I have asked him to be the devil's advocate. So, but just to share a little bit of perspective on what I learned setting up the program in Singapore. Just a few short points. Number one is that I think in the West, when you were on fellowship in MD Anderson, and in my experience in America and in the West, there is 10 times more prostate cancer than there is in Asia. So there's a lot more low risk, low intermediate risk cancer being identified. I think it has to do with the penetrance of PSA screening as well. So Singapore has as much PSA screening, I think, as there is in the West. So we are picking up a lot more small cancers with MR and biopsy. So in that sense, that's similar. But we do see the other spectrum as well, which are the more aggressive cancers. So for us, I think it becomes so important to really select the patients well. I totally endorse the points raised, which are that trust your radiologist, find a radiologist you trust, and only trust that radiologist. Trust your own biopsy, because I think that's where you're going to get the right selection. Whenever I try to be more permissive and say, okay, someone else did a 12-core systemic and or someone else did a 1.5 Tesla MRI, I get failures. The other thing is that I think margins are so important, and that's been raised by all the panels. So I think that like when you treat with a 5 millimeter to 10 millimeter margin, and I think the guys getting the best results, honestly, they're treating with a 10 millimeter margin. Pin would tell you that's what they do at NYU. They have great results on cryo. But by the time you treat with a 10 millimeter margin, it's at least a quadrant ablation. So that's in my practice. I wish I could do true target ablation, but I end up doing mostly quadrant, if not like 2/3 of a side of a prostate ablation. Yeah. So that I think is the context that I have. The other advice would be, I asked the question about 4+3s. I think there are a lot of unknowns once you start pushing the 4 barrier, 4+3 or 4+4, and I think that if you treat 3+4s, which I think is the sweet spot, it will be very safe. You will start off with a program that is going to have good results. But as you get more experience and more patients come, you're going to want to push the barrier, and I think that's where we will learn more. So I think there is a part of focal that we have enough experience and evidence that shows that we can do it, but you know, when it comes to science, we want to push the boundaries, and that's where we probably need a lot more tools. That's just my 2 cents. Yeah, and it would be great to hear from everyone else.
I think we're going to have to close the session soon, but I'll leave with one piece of advice that someone gave me. I worked with Mark Emberton, and in 2011, he told me that prostatectomy is going to come to an end. The volume is going to go down drastically. He's like, I no longer do radical prostatectomies. And I can tell you, 6 years ago, I stopped doing it regularly. Like, I will proctor my partners and help people when needed. But I no longer do radical prostatectomies. I also am an interventional radiologist as well as a urologic oncologist, so there's only so many days in the week. But as you buy into this and you develop these programs, your hospital administrators that base their business models on how many prostatectomies you do will be sorely disappointed. At our institution, 25% of our prostate cancers on the urologic service line are treated with focal. That doesn't include the active surveillance, which we only have of people that are candidates for active surveillance. 93% are on active surveillance. So we track all this stuff. So you're seeing this titanic shift to active surveillance and focal, and I think it's only going to continue to grow because the UCL data said that all the candidates that are candidates for focal therapy or for surgery, 50% of them could have been focal. So you're going to see this shift as you guys implement this new technology, and certainly now is substantially different than 2011. And I think there's so much more to come with advancements in imaging, technique, guidance, and we're really at the beginning. I feel it's amazing that I've been in the field since 2009. So much has happened, but there's so much more great things to come, and I hope you remember how to dock a robot 5 years from now.
I disagree with that. I actually perform as many radical prostatectomies as I perform focal therapy.
Now,
I think that at the end of the day, if you cause the failure in focal therapy in the patient, it's your job to salvage the situation.
you have to have partners to deal with this.
I guess you can send all your failures to me. We'll take care.
I don't mind at all. We only have a 95% success rate. So, and we don't do 1 centimeter. We do 8 millimeters the 6th, and you know those are our challenges. If you can't see, you treat more. You're the blind man.
I don't get a rebuttal to that, I guess.